All right, so good morning, everyone. Thank you so much for joining Emory Healthcare's Health and Wellness Speaker Series for DeKalb County School Districts this morning. We are excited to be back this school year with everyone. Hope that the year is going well so far. Can't believe we're almost in October. And so our presentation for you all this morning, which we're really excited about, is titled A Good Night's Sleep with Dr. Ann Rogers, who we are really excited to have with us and join us. She is both an Emory Healthcare clinician as well as Emory University faculty and researcher. So we are very excited to have her with us. And just to introduce her before I pass it over, she is a professor. She is tenured and nationally renowned sleep expert who joined the Nell Hodgson Woodruff School of Nursing at Emory University back in 2010. Her research career spans over 3 decades, and she is focused on patients with narcolepsy as well as other adult populations who obtain insufficient sleep. She obtained her doctorate degree from Northwestern, her master's in nursing degree from the University of Missouri at Columbia, and her bachelor's degree in nursing from the University of Iowa College of Nursing. She also, somewhat recently in 2021, was appointed director of Emory University's Emeritus College as well. So with that, I will pass it off to Dr. Rogers to get us started.
Okay. I'm happy to be here. Most people find the topic interesting. I'm going to have to back out. I want to move that menu bar out of the way. So it'll take me just a second. I didn't realize where it was going to pop up. Now, you'll be able to see my slides clearer. Okay, I'm going to talk some basic information about sleep, talk about how sleep changes across the lifespan, and symptoms that really require assessment and treatment by a specialist, and then leave time for questions and answers, because it's something a lot of people have questions about. So this is for your own information. Think about how much sleep you got last night, and then how much do you need? If there's a difference, it may suggest you're not getting enough sleep. So I'm going to go over some basics right now. The amount required for good sleep is really not known. We know that people who don't get enough sleep have a higher risk of becoming ill or dying. And we know that those that get more than 9 hours of sleep are also associated with higher risk of health problems and dying. And because of the way the studies are done, it may be they were sleeping a lot because they were already sick, or they weren't getting enough sleep because they were in pain. So we can't really tell, other than we know not getting enough sleep or sleeping too much isn't associated with good health. We do know that if you don't get enough sleep, it's common among all ages, including little children, which is a parent who's raised a kid, that kind of surprises me, because when a kid is tired, they're not particularly pleasant to be around. We do know that people that don't get enough sleep is associated with an increase in diabetes in women, an increase in type 2, and increased in insulin resistance. And insulin resistance is the condition that precedes the onset of type 2 diabetes. And this was data from the Nurses' Health Study, where they've literally followed nurses with questionnaires every year since the early 80s. And it's quite striking that if you don't get enough sleep, you're higher risk of developing diabetes. We also know that there is a dose-dependent relationship between sleep duration and obesity. You cut back on sleep maybe an hour, your percentage goes up a little bit. You cut back on sleep 2 hours, your percentage goes up twice. So it really, the more severe the sleep deprivation or insufficiency, the higher risk of developing obesity. And this is held true in all ages across the Western world. They've followed people for years and seen that again, or they've just done one-time studies, which really suggest it's a strong relationship. And there's a reason when we don't get enough sleep, our appetite regulating hormones bump up. And if we were starving, it would be helpful to us to crave high fat, high calorie food, but most of us aren't starving. And it's a risk factor for developing high blood pressure. Of course, family history is a part of it. Weight is a part of it. But even if somebody doesn't have a family history, isn't obese, if they're not getting enough sleep, they're still at risk for developing high blood pressure. So things that affect sleep. I used to show a TV here, but now I show a cell phone. Any electronic device emits blue light, and some of them say they're going to control it, but we don't know how much that works. It dampens melatonin secretion, makes it harder to fall asleep. So if somebody's having problems falling asleep, we recommend they put away electronic devices an hour or two before sleep. Caffeine, most people know about. It makes it harder to fall asleep later. Sleep, it's found in coffee, of course, but tea, cocoa. It's also found in a lot of cold medicines that say non-drowsy producing. And if you look at them, they list caffeine as an ingredient, so it can hide. Exercise, I wouldn't condemn it. Everybody needs to exercise for health, but don't exercise too close to bedtime because that increases the arousal and it makes it harder to fall asleep. Also, sometimes when people are pushed for time, they do all their exercising on the weekend and then they end up with muscle pain, which makes it harder to fall asleep. But it's good for cardiovascular, so you have to figure out when to exercise without keeping you awake at night. The light bulb, most people don't recognize it, but sleep durations have decreased since we started using electric light. And this is particularly pertinent for shift workers. It's very difficult to fall asleep when the lighting is on, and your exposure to light at night can make it more difficult to fall asleep. A lot of people don't think of alcohol, and yes, it may make you drowsy, but it fragments sleep and makes sleep lighter. And people that are consuming excessive amounts, it can really mess up their sleep, and they will have disrupted sleep even after they get off alcohol. And it may take several months before their sleep improves. And one that people don't think of is cigarettes. Nicotine is a stimulant. And so again, it makes it more difficult to fall asleep. And when I see people in clinic, I am going to ask about caffeine, exercise, alcohol, smoking, because all of those can really make a difference in your sleep. And this is just a clip of sleep stages. The dark bars are REM sleep or dreaming sleep. And you'll see what they've labeled N2 and N3 is the deeper stages of sleep. Most of your deep sleep occurs early in the night. Most of your dreaming sleep occurs closer to morning. And this is a normal pattern for adults. Sleep does change as we go through life, like everything else. Anybody that's had a newborn in the house knows they may sleep 18 to 20 hours or more, but they don't sleep all in one block. They can only maintain sleep for a couple hours at a time. They wake up, need to be fed. The brain isn't mature enough, and putting cereal in their bottle or whatever won't help them sleep. They can't digest the cereal, and you just have to let them get a few more months of age before they can sleep longer. They can't stay awake any longer than they can stay asleep. By a year, they should be sleeping through the night. And of course, sleep community says sleeping through the night was 12 to midnight to 5 in the morning, and that's doesn't seem like sleeping through the night. But if you've been awake every couple hours with a baby, that feels pretty good. By the time they're toddlers in preschool, they are sleeping a long duration at night with a nap in the morning and the nap in the afternoon. And the preschooler begins to give up the afternoon nap. I remember when my kid was that age, I found the kid asleep in the middle of the floor with Lego around dinner time one night after the first time giving up their nap. And then a couple days later, was no longer falling asleep. But this is normal. Maturation, all of their sleep gets clustered back in one block. They go to sleep, they wake up in the morning full of energy. If they're having trouble going to sleep, there may be a health problem, or more likely, what they found is the kid is watching TV or using a screen. Kids that age have a lot of nightmares. They can't sort out what's real versus fantasy on TV like we can, and it scares them. So a lot of the sleep problems in toddler and preschool age, we look at what's going on in the family and what the sleep patterns are and how much TV is being watched. School-age children sleep the best they're going to sleep in their life. They fall asleep easily, they get up refreshed, they're able to stay awake all day, shouldn't have any trouble with sleepiness or falling asleep unless they've got some health problems. Autistic children certainly have some issues, sometimes going to bed and staying asleep. And then we move into the teenage years, and they don't like to go to bed early. And physiologically, this is driven by how far they're into puberty, and they can associate it with the stages of puberty. And they often have to get up early for school, and so may not be getting enough sleep at night. Another thing that interferes is oftentimes there are early morning practices for swim team that make it difficult, and some states have decided to move the school start times back, which conforms more with their physiologic alertness. And we do begin to see some sleep problems cropping up in our teenage kids. Adults fall asleep within 20 minutes. If somebody comes into clinic and tells me, fall asleep as soon as my head hits the pillow, they're either not getting enough sleep or they've got a sleep disorder. Adults sleep approximately 8 hours out of 24. It's all in one block at night, unless they're not getting enough sleep and they may nap. And they're able to stay awake and alert throughout the day. If you're getting enough sleep as an adult, you should be awake and alert throughout the day. And I'm going to talk about some things that may cause problems a little bit later. Middle-aged adults, again, their sleep is pretty good, but women may view it as a disposable commodity. They may get up early to exercise. They stay up later to complete household chores, particularly if you're juggling work and family. Menopause itself does not lead to disturbed sleep. Hot flashes don't disturb sleep. What happens is the person wakes up and then realizes they're having a hot flash. And they don't recommend using hormone replacement just to treat disturbed sleep. Certainly if somebody's having severe hot flashes, they will put them on. And sleep complaints should be investigated and not written off as menopause. And that typically was the way it was looked at in the past. And we begin to see more frequent occurrence of sleep disorders such as sleep apnea and periodic leg movements. And I'm going to talk about those in a little bit. And you see this occurring both in men and women as we age. Our older adults, again, falling asleep within 20 minutes. Sleep approximately 8 hours out of every 24. But particularly in our retirement aged and in the 80s, it may not be just in one period at night. It may be, there may be napping, and it may be because they need the sleep, or it may be that, social things such as retirement and boredom may play a role. So we do begin to see napping occurring. We do see sleep changes with age. Sleep latency is how long it takes to fall asleep. You see that's pretty much unchanged. WASO is wake after sleep onset, and you do see that increasing in middle age. It's the blue line compared to childhood, and you have more arousals as an older adult. The red area labeled REM is dreaming sleep, and you can see that percentage really doesn't change as you age. Slow wave sleep is the deeper stage, and you see that really is a lot of deep sleep in a child and tapers off and you get in your 80s. And actually we see women have more deep sleep preserved, even though they're complaining of poor sleep compared to men. And stages 1 and 2, the lavender, you see definitely increase as we get older. Or stage 1, which is the lightest sleep, definitely increases. And people sometimes are not even aware when they're in stage 1 sleep. I know my grandfather would sometimes fall asleep on the couch. We'd hear him snoring. He'd say, "No, I wasn't sleeping. I was resting my eyes." Well, he probably was in that lighter stage of sleep where you really don't know if you're asleep or awake. You hear things, respond to the environment. And this is a slide put out by the National Sleep Foundation showing the recommended duration. And you can see that it does decrease over our lifespan. But as adults, we really need 7 to 9 hours. Older adults, 7 to 8. Our teenagers need 8 to 10 hours. Many of them are not getting it. People think they can get by on shorter sleep. There's only a handful of people that really can function well with 6 hours of sleep or less. And they'll often find that out when they go on vacation, sleep more, and they notice how much better they feel. So things that require your attention about sleep. This is old data. They haven't calculated how much sleep disorders cost in 2023, but we know it affects 50 to 70 million people in the US, costs billions of dollars in medical expenses, lost productivity, and accidents. There are over 80 distinct sleep disorders. Certainly insomnia, a lot of people are familiar with difficulty falling asleep, staying asleep. There's sleep-related breathing disorders that I'm going to talk about. Hypersomnias of central origin or narcolepsy and idiopathic sleep disorders. Circadian rhythm sleep disorders. Some people are very much early morning people. They wake up early in the morning. They're sleepy early at night. Other people are very much night owls. They're not sleepy until 1 or 2 in the morning, and they sleep fine if you let them sleep till 10 or 11. Parasomnias would be the night terrors, things that happen in sleep. There are sleep-related movement disorders like kicking. There are isolated symptoms, and normal variants would be like if you fall asleep and you notice your muscles jerk, that's perfectly normal. And then there are some other sleep disorders. I'm going to talk about a few that cause real problems. Most patients, however, remain undiagnosed and untreated. And unfortunately, the statistics for those that have sleep apnea that are undiagnosed and untreated really haven't improved a lot. And this is a disorder that can cause major health problems. And we'll talk about it. When to seek treatment is if you're acting out dreams. Normally during dream sleep, we're paralyzed. We can't move. Our heart beats, we breathe, but our muscles are still. And if I were to pound on somebody's knee with a hammer during dream sleep, even the automatic reflex wouldn't be there. But if your partner tells you you're swearing, shouting, your arms are flailing, there are violent kicking movements, pay attention, even if you're not aware of that, because you should not be able to act out your dreams. And people that have this disorder often say they are being attacked, their spouse is being attacked, and they are trying to protect themselves or their spouse. And there's a moving YouTube video about a man in Minneapolis that has REM sleep disorder. And he was awake, his wife woke him up when he was trying to choke her. He was dreaming there was an intruder and he was protecting her. As I say, movements can take form of kicking, punching, leaping out of bed when they're dreaming. They can be injured. Self-injury occurs in 1/3 to 3/4 of the patients, with 11% of those injuries requiring medical attention. 2/3 of their bed partners report being assaulted or injured. Risk factors: being male, more common in men than women. If you're over 58 years of age, it's more common. And we often see it associated with Parkinson's disease, Shy-Drager, multisystem, Lewy body dementia. It doesn't mean that patients have it. And in the case of Parkinson's disease, they may see the REM behavior disorder first and develop Parkinson's disease later. But just having REM sleep disorder doesn't mean you're going to develop dementia. And it can be associated with alcohol use, sedative hypnotic withdrawal, as well as some of the drugs that we use for treating depression. And if you're on one of these drugs and symptoms begin, they can switch you to a different drug. How do we diagnose it? We're going to ask you about your health, your sleep history, exposure to pesticides, alcohol, smoking, and we like the bed partner to attend the appointment because we can get a different perspective from them. They can tell us what's going on. And the person will need to stay overnight in the sleep lab with a video recording. And the insurance covers this. But we need both to see what's going on. And even if the person doesn't have an episode that night, we'll often see increased tone, muscle tone during REM sleep, even if they're not moving around a lot. It's treatable with medication. We do watch clonazepam. It's a drug like Valium, because it can make you sedated. It can cause worse sleep disorder breathing. And melatonin actually can help with this in different doses than we might use for insomnia. We also focus on safety. Put pillows beside the bed, put pillows between the patient and the bed partner, remove firearms from the bedroom. Want to make sure they don't fall out of bed if that's a tendency. Pad the corner of the nightstand so if somebody's flailing, they don't hurt themselves. The next one is when to seek attention with insomnia. All of us are going to have a little difficulty falling asleep before an important exam. We have a job interview, we're traveling, but you do need to pay attention if you're having trouble falling asleep or staying asleep for more than 4 weeks. Certainly hospitalization, any of these stressors that occur, or even getting up regularly with a baby, even after the baby begins to fall asleep and stay asleep, your pattern of waking up at night can become chronic. And so if you're having trouble for more than 4 weeks, it is time to see a sleep specialist. Wouldn't recommend starting with your internist or general practitioner because they're likely to prescribe sleeping pills, and that isn't the most effective treatment. One of the things that people do when they can't sleep is they're going to stay in bed longer in hopes they fall asleep. That actually begins to unconsciously associate your bed with tossing and turning, and that makes it even harder. And of course, if you look at the clock, oh my gosh, it's 3 o'clock in the morning. I've got to go to work. What am I going to do? That only drives up your anxiety and makes it harder to fall asleep. It's also a concern if your difficulty sleeping at night make it hard to function, make it unsafe to drive. So it is important to seek attention if it's occurring on a regular basis for several weeks. Risk factors: females, being women, we're more likely to have trouble falling asleep than men. Those over 60 are more likely to have trouble staying asleep. Our younger patients prior to 60, it's more trouble falling asleep. Women during menopause and women and men over 60, it's staying asleep because their sleep is lighter and more easily disrupted. Mental illness such as depression, anxiety, and PTSD are all associated with insomnia. And in fact, you may see the insomnia before the depression symptoms occur. Stress, as I mentioned, an exam, a job interview, even the first night in a hotel on vacation, it may be harder to fall asleep. And shift work, a big one. Our bodies are not designed to be awake at night or fall asleep during the day. And if you are working shifts, it is much harder to fall asleep. In the morning, we recommend, light blocking shades, quiet, etc. How do we diagnose it? It's really sleep history. We're going to look at your medications because many of them, even certain antidepressants, promote wakefulness, others promote sleep. We're going to look at your habits related to caffeine, alcohol, and smoking because those can contribute. And I remember when I was at University of Michigan, we had a teenage patient that was consuming, I forget, a couple liters of regular Coke, or maybe it was Mountain Dew that has a lot of caffeine in it. And we had his parents restrict the amount of soda he was drinking, and his insomnia disappeared. So we're going to ask a lot of questions about your habits. And people are variably sensitive to caffeine. Some, if they have any caffeine afternoon, they're not going to fall asleep. I can remember working evening shift 3 to 11:30, drinking coffee, falling asleep without any problems. But that sensitivity often increases as you get older. We don't require a sleep study. If we did an expensive sleep study, it would just show us that your sleep was rotten. You had trouble falling asleep or staying asleep. So we're not going to recommend a sleep study unless we suspect another sleep disorder. And I do often see this in our middle-aged women that are postmenopausal. They'll come in complaining of they can't stay asleep, and they will get a sleep study because we're suspicious for sleep apnea. And I'm going to talk about that. Treatment, yes, we can use sedatives and hypnotics. They're appropriate for very short-term use, maybe being in the hospital where it's noisy. They are not a long-term solution. They lose effectiveness. They can be addicting. They can hang around and give you a hangover effect. Stimulus control relates to, as I said, we begin unconsciously to associate our bed with sleep. So we have patients, if they don't fall asleep within 15 or 20 minutes, to get out of bed, do something quiet, read a book, not your iPad or phone, go back to sleep when you're sleepy. We caution them that they're going to be up the first night. Don't nap during the day. And by the time the next night rolls around, their drive for sleep is pretty strong and they'll fall asleep. This is actually more effective than sleeping pills. It's been shown to be one of the most effective treatments. And it's something, if the sleep problem reoccurs, that the patient can reinstitute on their own. And it's something people need encouragement to do. It just seems so wrong. I can't get to sleep. get up and do something quiet. We also use cognitive behavioral therapy and a few sessions, either with a psychologist, nurse practitioner, or sleep specialist. We look at what's happening to you, what's going to happen if you do lose sleep. Is it really going to lose your job, etc.? This is very effective. It's short-term therapy. Doesn't mean you're crazy. And there are now apps developed by sleep specialists they've shown are just as effective as going in and meeting with the psychologist a few times. So there's real good treatment for insomnia. And when to seek treatment for snoring. If your snoring is loud enough to disturb your partner's sleep, and we joke about elbow therapy, meaning the spouse or partner elbows you to turn over. If it's disturbing your partner's sleep, that's a problem for them. And we often have patients that their spouse is migrated to the couch, the guest room, etc. If somebody tells you you stop breathing or gasp when you're sleeping, this is not normal. This is a dead giveaway you have a sleep problem. If you have excessive daytime sleepiness, because what's happening is you're waking many times an hour for a few seconds to breathe, so you're losing sleep. If you have any of the following problems: high blood pressure, heart disease, history of stroke, or frequent urination at night, we often see people saying, I have to get up 3 or 4 times a night. And even for an older man in their 70s with prostate problems, they shouldn't be getting up 3 to 4 times a night. Obesity can make apnea worse over time, but it's not as big a risk factor in people over 60. People over 60 are more at risk for sleep apnea, even if they're not obese. But sleep apnea can trigger high blood pressure, heart disease, or stroke, as well as be strongly associated. We know that over half of the people with high blood pressure, particularly if you're taking 2 or more medications to control your blood pressure, also have sleep apnea. And treating it can make it easier to treat your blood pressure. But you don't have to have any of that or even be obese to have sleep apnea. And here's a chart, and I recognize it's really busy, but it shows how many people with health conditions have sleep apnea. For example, 83% of those with taking 2 or more medications for high blood pressure have sleep apnea. 3/4 of those with congestive failure have sleep apnea. Over half with atrial fibrillation or irregular heartbeats have sleep apnea. And I know of cases when treating the sleep apnea reduced the amount of medication a person was taking to control their atrial fibrillation or irregular heartbeat, and even the need for cardioversion, where they would shock somebody and hope to get a normal rhythm. So you can see diabetes. Many people have sleep apnea. You have surgery for a brain tumor. Many people have it. Alcoholism, even glaucoma. High number of patients have it. Of course, that's age-related. And sleep apnea is one type of sleep-related breathing disorder. 4%, 2% of women and men doesn't sound like a big deal, but it is, given the number of people in the United States. We also see it up to age 50. Men are more likely to have it than women. When women hit menopause, we're equally likely to have sleep apnea. And when women hit menopause, it isn't related to weight. It's related to estrogen dropping, making the muscles of the airway more flexible. And I know a number of postmenopausal women that are slender and have sleep apnea. and they come into clinic complaining of their sleep not being very restful, waking a lot, and it's really related to their sleep apnea. We also know people with smaller jaws are at risk just because they have small airways. Only 10% of patients are receiving treatment, and the majority of those with symptoms have not received the diagnosis. And we know untreated sleep apnea can lead to cardiovascular disease, hypertension, or stroke, even if you don't have risk factors. And I think people remember Justice Scalia was found dead at night with his CPAP sitting on the side of the bed unused. It's rare that somebody dies in his sleep, but that is a concern if it's severe enough. And I've seen patients that have sleep related breathing pauses more than once a minute, and their oxygen desaturates. And they've been living this way for quite a while. So what is apnea? We say number of breathing events per hour, more than 5. In adults, if a child has more than 1 an hour, we get concerned. And obviously we're going to have to test to determine how many events per hour. It's often accompanied by oxygen desaturation, and we see the heart rate slowing down as they're not breathing, and then it picks up and is extra fast as they start breathing again to compensate. This video, I'm not going to play it. Sometimes the quality isn't good. This is a very large man in the sleep disorder center being tested for sleep apnea. He literally stops breathing for almost a minute, and then when he starts again, you hear this loud snorting, gasping sound that's pretty typical. So how do we treat it? First thing we can do, if it occurs only when somebody is on the back, this would be a milder case, is use the positional therapy, a certain pillow, sort of device strapped to your back so you don't roll over. Patients learn to roll over. They usually discard that. Oral appliance looks like something you might wear as a retainer. After you have braces, might wear as a mouth guard for sports, and it literally pulls the jaw forward a few millimeters, opens up the airway. Again, this works very nicely for people with mild apnea. And I'm making the distinction. They have 15 events or less an hour. There's a debate even if they need treated, but if they're sleepy during the day, they're coming to clinic, they're obviously not feeling rested. I believe in treating them. Some people don't because it's not associated with, high blood pressure, heart disease, stroke. The next thing they can do is surgery, uvulopalatoplasty. They go in and carve out all that excess tissue in the back of the throat, the uvula, the thing hanging down. Problem is that only works about half the time. And we can't predict who it's going to work for and who it's not going to work for. If somebody's in their 20s, they're healthy, they want to try it, we do have a specialist at Emory that specializes in surgery for sleep apnea. They're a good surgical candidate, young, it's worth a try. But we're not going to recommend it for everybody. Nasal CPAP, which is down below, everybody's heard of that. People dread it. I don't want to wear a mask. It works on 98% of the patients. They do have to wear the mask, and we've got probably hundreds of different styles. Masks, they're no longer this big thing that fits over your face, like an oxygen mask in the hospital. The machine is quieter than a fan. People worry about it disturbing the partner, but it really disturbs the partner less than your snoring. People can get used to it. We've got all sorts of techniques to help them get used to it. It works. Excite OSA is a new device. You can see the guy has it in his mouth. It runs off an app. It's a little stimulator. It literally stimulates the muscles of the tongue to contract, and the theory behind it is exercising the tongue muscles during the day for 20 minutes will make them stronger, more likely to resist falling in back of the throat and causing the airway blockage. Again, it only works for mild apnea, and it isn't always the tongue falling back in the throat that causes apnea. It's further back, but certainly in patients with mild apnea, that may help. The final one is this hypoglossal nerve stimulator, and this is the one, Inspire, that's on every TV ad. You can get rid of your CPAP. Just have this. It is surgery. They implant a device under your collarbone like a pacemaker. It threads up through the phrenic nerve. It pushes you turn it on with an app, and it pushes the tongue forward to unobstruct the airway. Again, lots of patients coming in wanting Inspire. The thing is, your BMI has to be below 35. They don't want to take you into surgery if you're at risk, because surgery can cause complications, and it's dangerous. Basically, anesthesia can be dangerous for anybody that's any surgery. They're not going to take you in and cause you additional risk if your BMI is higher. We know apnea patients are harder to put the tube down the throat to help you breathe during surgery. So they're very selective. Also, your insurance company doesn't want to pay for surgery if you haven't tried the non-invasive kinds of therapy. So they're essentially saying, you have to try nasal CPAP, you have to prove it doesn't work for you, and that you're a good surgical candidate. It can work for the right group of patients, and they're very happy, but it's not for everybody. And a lot of times when we talk to patients, they're like, no, I really don't want to go through surgery. I'll go back to my mask. So there are a variety of ways to treat apnea. There's also a newer one that has been FDA approved, but it is not covered yet by insurance. And it involves putting a device in the mouth. It's not nasal CPAP, it's much smaller, and it provides some suction, pulling the muscles of the tongue forward and the airway open. But since insurance doesn't cover it yet, I didn't put it on the slide. And of course, there's weight loss, which is harder to achieve than people consider. And a lot of people, well, I'll lose weight and then I won't have to go on CPAP. We usually suggest going on CPAP first, losing the weight, and then testing to see if you can do without it. And my late partner was able to get off CPAP after he moved down here, began eating healthier, healthy diet. We can't predict whether it's going to take 5 or 10 pounds or it's going to take 50. But it helps your health in general if you're overweight. Now, our slender postmenopausal women, their BMI is normal. It's not the cause of their apnea. So they're more likely, particularly if it's mild, to use an oral appliance. So we do have to bring you into sleep. You are going to get an appointment. We're going to talk it over with a sleep specialist. And we may do a home test or a lab test, depending on your insurance and how severe and what we think we're looking at. I advise you to use an accredited sleep disorder centers. The health hubs at CVS, the nurse practitioner can write the prescription for the sleep study. It's a home study. They send it off to a company to be scored. You come back, then they prescribe CPAP, and there's limited follow-up. They're not specialists. They can't help you when you're having trouble with your mask or machine. So obviously, I'm part of the Emory Sleep Disorder Center, so all you have to do is call up to schedule an appointment. We don't have to have a referral, although your insurance may require it. We do see patients at Midtown, but most are seen at Executive Park. We do all of our sleep studies there. If we think it's sleep apnea, and most insurance is going to want you to have a home sleep test, which doesn't really score sleep, but monitors your breathing and pulse and a few other things. We'll send it out to you, mail it, you mail it back. If you're not in the Atlanta area, you can use the link to find an accredited sleep disorder center, and you type in literally your zip code, and it will find you all the sleep disorder centers in the area that are accredited. This is not the CVS Health Hub or somebody that's just running it for profitability, to be honest. It is being slow today, so I'm going to go back to my slides. Anyway, they're all over. Depending on your insurance, Piedmont has a sleep disorder center. I believe Northside might. There are several accredited ones in the Atlanta area. I will say that we're often backed up for appointments. When I started in 2010, we had 4 people in the sleep disorder center. There are 4 providers. Now there are 12, and we stay busy. And you can see it's multidisciplinary. We have people that specialize in lung diseases, and they got involved because of sleep apnea. We have people that specialize in neurologic diseases of the brain and spinal cords. Dr. Rye is he does a lot with periodic limb movements and restless legs, which are very painful. Don Blywise has been in sleep longer than most of us have, other than Dr. Rye, and he's a psychologist and does a lot with insomnia and aging. And all of us, nurse practitioners, will see patients with a variety of disorders. So there are plenty of people available to provide help. There is often a wait period. And unfortunately, there are more people with sleep problems than we have providers that can solve the problem. So what I'm going to do now is take questions. I'll stop sharing on computer. And I'll take your questions, because I find people have a lot of questions usually.
Thank you so much, Dr. Rogers. We had one question come in during your presentation, which was just somebody asking if this recording will be shared afterwards, which yes, we will be happy to do that and get that sent to everyone. But again, for questions, comments, folks are able to use the chat functionality as well as the question and answer function. And I can also go ahead and give you all the capability to unmute yourselves as well.
Is it common not to remember dreams? Absolutely, unless you wake up for 1 to 2 minutes after a dream, you don't remember it. And I know, and I was testing some equipment one time, I have no sense of remembering a dream, but the EEG that I was, portable EEG that I was testing, showed that I had dream sleep, but you have to have an arousal right after. And since most of our dreaming occurs early morning, that's more likely to occur right when the alarm goes off. So that's perfectly normal. Somebody said, how long is it safe to take melatonin? We don't really know. Use the lowest dose. If you're going to take melatonin, don't take it immediately before you go to sleep. It takes a couple hours. And once you take it, stay off your phone, your iPad, away from the TV, the computer, because all that blue light suppresses melatonin levels. You've just taken a drug to increase your melatonin, so you're sort of wiping it out. Somebody says, can you have a combination of sleep disorders? Absolutely. We see periodic limb movements, restless legs more often in patients with sleep apnea. It's sort of like when one system is breaking down or aging, you're more likely to see problems. Certainly your restless legs can make it difficult to fall asleep. Why can't you go back to sleep? You wake up to go to the bathroom. Sometimes it's because you've had some deep sleep and it's going to take you 15 or 20 minutes. You should lay quietly in bed. Do not turn on the TV. I know a lot of people use that to get to sleep. If you're waking up to go to the bathroom at night, and you don't have prostate problems, and you're not drinking a huge amount of water, we might want to check you out, particularly if your partner says you're snoring, because our body, the endocrine system, is designed to concentrate urine at night and not wake us up. Now, certainly, older people may have trouble, certainly older men with prostate problems, but they need to see the urologist to deal with prostate. And we do get a lot of middle-aged women coming in saying, I wake up, I can't get back to sleep. I wake up every night at 2 or 3 in the morning, have to go to the bathroom. And then we start asking them about snoring, and they've got sleep apnea. See, sleep disorders certainly can trigger anxiety, particularly the insomnia. You know, if you're having trouble getting to sleep, you're worrying about how you're going to do on your job the next day, your family, whatever's going through your mind, it can trigger anxiety. We also know patients with underlying anxiety disorders are more likely to have sleep. So anxiety and depression are very vicious circles related to sleep. Good questions.
Keeping an eye out to see if we have any more coming through. I know a question I had, I know you'd mentioned, you know, sugar and caffeine and stuff, but how can food and timing of when people eat and what they eat impact sleep as well?
Actually, food doesn't do that much unless you're overloading on caffeine. For people that eat late at night, there is a GERD, gastric esophageal reflux, that can keep you awake. You need to elevate the head of the bed, avoid that. Sugar doesn't make it any easier or worse to fall asleep, doesn't make your kid hyper. We actually need a certain amount of sugar, glucose, for our brain to work. I wouldn't recommend eating a lot at night. We know that's associated with weight gain. People that have reflux, it's worse. Somebody says their spouse still snores with his CPAP. Is this normal? No, it is a cause concern. They probably need to adjust his settings, may need a different mask. Somebody says something about the dental device. They just said dental device. They're still snoring with the dental device. They need reevaluated. You shouldn't be able to snore with those. Obviously, you get a cold, you have allergies, it may make things worse. But our newer CPAPs adjust the pressure on their own, but it may need reevaluated because people age, they gain weight, etc. And somebody's saying these conditions are untreated for a long period. It sort of depends. People that develop narcolepsy in high school aren't diagnosed. They're more likely to have an auto accident, fail out of school because they're sleeping, causes a lot of social problems with treatment. They do fine. I know some nurses and doctors with it, lawyers. If it's sleep apnea, you run the risk of developing high blood pressure, heart disease, etc. The wait for an appointment can be variable. I would say it's a couple months. Oftentimes, don't wait till the end of the year. Everybody's deductible. You have to meet a certain deductible. So they wait till they've met it, and then we're overbooked in December. And unfortunately, we can't see all of our patients that want a December appointment. So spread it out among the year. I wish there weren't waits for appointment. If you're willing and have the flexibility, tell them to put you on the wait list. They'll call you if we get an appointment opened up, because people, have things come up and skip their appointments. Somebody says, are there 3 treatments, dental device, CPAP? I'm assuming they're meaning Inspire, meaning the surgery. Those are the main treatments. CPAP is covered by insurance. What they do, though, is you have to use it a certain number of hours, certain number of nights per week before they pay for it. And they rented it first. And it used to be people would come in and tell us, oh yeah, I'm using my CPAP. And we'd look at the counter and it showed 3 hours in 3 months. Nope, 0 hours in 3 months. And now they're saying 6 hours a night, 5 nights a week, minimum. The first 3 months, if you don't meet that, we ask the patients come back in, and actually insurance requires it to make sure it's working. We can problem solve mass spit problems. We can adjust the pressure. We can turn down the ramps so that you get a very little pressure when you go into sleep, and it increases to the pressure you need when you're asleep and don't realize it. But insurance does cover it because it's cheaper than paying for your heart attack. And if it's causing issues with your insurance, the sleep provider should be able to sort it out. It is covered. You want contact information. I assume that you will put it in the chat. The best number is to use the Emory sleep disorder. You can also use my email, but I'm not comfortable giving medical advice over the phone or email. If you say I'm having a certain problem, I'll say, please see a sleep specialist, because I'm not sitting down with you for a half hour going over your entire health history. I can tell you who to go to, and I can answer basic questions, is snoring normal using CPAP or something like that. I can't give you medical advice without really sitting down. And Lindsay, I assume you have my email and could put it in the chat.
Yep, so I'm about to put that in there. I also just dropped the link again for the sleep center, and that brings you to their website, which has the phone number for what to, where to call to make an appointment and see the team that Dr. Rogers shared with us and everything. So that's all in there.
And it doesn't matter what you're coming in with, insomnia, sleep apnea, all of us, except some of the nurse practitioners, are boarded in sleep disorders medicine. We're qualified to treat a variety of sleep disorders. It doesn't matter who you see, we'll get something started. And just to caution you, I am full-time faculty, so I tend not to check email until the end of the day.
Yeah, I was going to say, I think the best place for everyone to go if they're interested in making an appointment, seeing a provider, I would say go to that website for our sleep center and call that number to get started to make an appointment.
Yeah, and I can provide references like the American Academy of Sleep Medicine, which has the site that if you live outside of Atlanta, Decatur area where there are sleep providers, and they have a lot of resources. Stanford University has some good resources. Harvard University has some good resources. The resources you don't want to Google are, I'm going to sell you this magic supplement that will fix your sleep problems. Go with a university or medical center, sleep disorder center for your information, because there's a lot of it out there. There's hundreds of apps, many of them developed by a computer guy that may not know much about sleep. But there are a few, like I said, they've shown that are just as effective at delivering cognitive behavioral therapy through an app as the provider. And this was developed actually by the VA health system, because they don't have enough providers, and many of their patients are in some rural areas. Other questions?
Think. It looks like we got lots of other folks saying thank you for the presentation and for the helpful information. So that is great to hear. Somebody actually just said it clarifies many concerns that they have, which is wonderful to hear that we were able to help with that today.
Yeah, and I'm glad to help with it. It's something that everybody can relate to. And one thing I enjoy about sleep compared to working in the hospital in the ICU is when we fix their sleep problem, they feel good. Many of our patients, when we left the ICU, they still had rehab and chronic health problems ahead of them. When people sleep, they wake up rested, they're able to stay awake during the day, they can do what they want versus struggling to stay awake, your spouse elbowing you every few minutes. I can make a copy of the PowerPoints. I'll have to send them to Lindsay.
Yep, I was gonna say, so I will, and I'm about to show you all something in 1 second. That's kind of a resource hub that we've created for everyone here. But first, I would just like to say thank you again to Dr. Rogers so much. We really, really appreciate you taking the time to share this really helpful information with everyone this morning. Clearly, it was very appreciated by our attendees here. So thank you so much.